All right. Good afternoon and happy National Rural Health Day. My name is Danae Aber. I'm the Executive Director of the Louisiana Rural Health Association. Thank you so much for joining us for this webinar on transforming Louisiana's rural health landscape. LRHA is happy to host this webinar presented by the Louisiana Department of Health. This webinar is being recorded and will be available along with a copy of the slides on our website, and I will drop a direct link in the chat just a minute. Your lines are muted when you joined, so please stay on mute to prevent background noise. If you have any questions throughout the presentation, please feel free to put them in the Q&A box and we will answer as many of those as we can. After the webinar, a survey should automatically open in your internet browser, and we do ask that you please complete that survey. It helps us to improve our future events and to identify future education topics that would be of value. And so with that, I would like to welcome Julie Foster Hagan, who's the Executive Director of the Rural Health Transformation Program, who's presenting today's webinar. Thank you so much, Julie, for being here. I'll hand it off to you.
Thanks, Danae, and happy National Rural Health Day to everyone as well. As Danae said, my name is Julie Foster Hagan, and I am the executive director, the new executive director for the Rural Health Transformation Program. I've been with the department for about 27 years now, working in the area, in the area of developmental disabilities, but also am a licensed speech language pathologist and have worked in rural hospitals, nursing homes, home health agencies in the past as well. And so they've asked me to take this on. So myself, along with Nicole Coursey, who I'll let introduce herself in a moment, have been working furiously to get the grant application submitted by the deadline of November 5th. And we'll be sharing some information with you today about that process, about the Rural Health Transformation Grant opportunity, and what Louisiana's approach is. So, Nicole, do you want to introduce yourself?
Sure. Thank you so much, Julie. I believe I know most everybody on here. I'm seeing a lot of really familiar names, but Nicole Coursey, I'm the Deputy Director of Programs here in the Office of Public Health at Louisiana Department of Health. And like Julie said, I've been working side by side with her in developing this grant application. I'm really excited about being a part of this effort. I think we have some really good initiatives, and I'm glad that Julie is here to kind of describe everything that we are going to be implementing over the next several years. So again, thank you so much for joining us, and happy National Rural Health Day.
And as Danae said, if you guys have questions as we go through, feel free to pop them in, and Danae will jump on and let me know if there are questions. So what we'll do now is really I'll share with you kind of, as I said, an overview of House Resolution 1 and the CMS Notice of Funding Opportunity related to the Rural Health Transformation Program, and then give you guys an overview of what we included in our application, and then share with you what our next steps are in relation to the Rural Health Transformation Program, and then spend a little bit of time just sharing our vision for the future of rural health with the department. So House Resolution 1 at the federal level, which was also called the One Big Beautiful Bill Act, included a Section 71401 that allowed for $50 billion in funding over the course of 5 years, specifically to help improve rural health infrastructure, workforce, and access. So through this grant opportunity, it means approximately $200 million per year over the course of the next 5 years for Louisiana. It may be a little more than that. It may be a little less, but we're anticipating that it'll be more. We'll share with you some of the reasons why we think so. But this portion of the reconciliation bill prioritized underserved areas with high morbidity and provider shortages. And unfortunately, one of the things that was included when it came out in the resolution, it said that CMS had to review all of the grants by December 31st and give the award. So from the time our notice of funding opportunity came out to the time that we had to submit our application was only about 6 weeks. And so in that 6 weeks, we had to try to hear from stakeholders as best we could but we also then had to pull together what our initiatives, what our strategies were. Without normally we have time to do public comment and public input before submitting things this large. But again, with that 6-week timeline, we were under the gun to get it in by the November 5th deadline, so that CMS could then get it back by December the 31st. So what the notice of funding opportunity said is they took the $50 billion in total funding, and they divided it in two ways. The first they call baseline funding. So if you are a state who applies and follows the regulations or timelines for it, then they will take half of that $50 billion and give it equally to all states. We know now that all 50 states did apply. So we know that the 25 billion, which then equates for us to 100 million a year in that baseline funding, will again be distributed equally among states. The remaining 50%, or the remaining 25 billion in total, is based on a few different factors. One of those is around data-driven metrics. So they identified certain things because Louisiana is a more rural state. We do anticipate when you compare us to other states, we will likely have higher points because of the rurality that we have in our state. The other factor that they looked at is around initiative based. And so that's basically they'll look at the quality of the information that's included in our application, in terms of how we look at being able to make long-term sustainable differences. They focused a lot in this application on not just funding in the way that we oftentimes traditionally look at grant funding, which is we get a program up and off the ground. And then what we often see with those programs is that once the grant funding goes away, the program goes away because we haven't thought through the sustainability piece. So one of the things that we had to make clear in our application is not just what are the initiatives we're trying to reach, what are the strategies we're going to employ, but how are we going to do that in a way that when we're finished with the grant itself, that things are sustainable and able to continue in different ways, which we've looked at in different ways depending on the strategy. There were also points awarded, and the points will equal to more funding. There were points awarded for certain state policy actions, and we'll go through and I'll share with you where Louisiana stood on those state policy actions and some commitments that the governor has made in relation to that. So they will be, again, all states submitted by the November 5th deadline. CMS is now under the gun by December the 31st to tell us what amount of funding we will have. And so I will share with you guys today, what we put in our application, what's proposed. But until we get the actual letter from CMS on December 31st, we won't know for sure what the exact dollar amount is, nor will we know if they indicated they may come back and say, well, we need more information about this. We're not sure this really fits with the grant. And so there may be some things that we have to adjust once we hear back from CMS, and as we work through the process. Because one of the things CMS has said is that they will have designated regional folks to work with us, and that they see the course of this grant application as being real partners. They're doing it through cooperative agreements between the state and the federal agency or CMS. And so they see it as collaboration. And so we'll be working together to refine this as we go along. The other interesting thing about this grant is that on December 31st, they will tell us what we will have for our first year of funding. But then each year by October the 31st, we will have to do a report on the data, on the metrics, on the successes we've seen, the use of funds, how we've spent the money, those kinds of things. And each year they will make a determination for how much you get the following year based on that report that we turn in on October the 31st. And so it's not an amount that we know over the course of the 5 years. It is an amount each year. And we could get more funding again or less funding depending on how we perform, somewhat based on what we put in the application, but also based on looking at us across the other states. And then finally, the way that this funding will go is we do anticipate getting money January of 2026. So we will get money early on to be able to start spending. And so we are, even though we still know that we've got we have to wait for anything final from CMS, we are already working on how do we start to think about being able to get the money out of the door as soon as possible in January, because they will give us a year and a half. Well, they will give us until the following federal fiscal year. So we will get the money in January, and then we will have until September 30th of 2027 to be able to spend that funding. So each year it's an annual amount that you have until the following federal fiscal year. So it's going to be a lot of tricky budgeting as we look at making sure we're following those guidelines, spending within our parameters, and all of those things that'll need to be reported to CMS.
Hey, Julie, we have a question.
Sure.
What is the state projecting for administrative costs?
So there was a limit of 10% for administrative costs, and Secretary Greenstein asked us to keep it at 1.5%. So we're anticipating very low administrative costs so that we can maximize the funds outside of the admin cost and make sure that we're getting them out in the communities as much as possible out in the communities. Is that it? Yep. Okay. As Danae said, she will give you guys these slides, so I'm not going to read all of this to you, but did want you guys to know, we'll go through kind of what did they say that the funds needed to be used for, as well as what did they say we cannot use the funds for. So as you can see, there's, it really kind of focused on care, prevention and chronic disease, appropriate care availability. There was a focus on behavioral health. But then they're also asking that we look at, we can use provider payments. We can use this, and they actually reinforce that we should look at training and technical assistance, because they feel like that's the piece that helps make a lot of this sustainable, not just that we get activities or things out, but that we are able to move them forward. Yes, Danae, was there another question?
Yeah. Is the baseline funding guaranteed for each year?
Yes, the baseline funding is guaranteed for each year. That's the minimum. Sorry, any more questions on that one before we?
Yeah. Who at the state level will be in charge of scrutinizing how the money is spent? Like, who has oversight of the money at the state level?
Sure. So a few different people. The governor, the way this grant was written is that it was required. It was a grant that required that it be submitted by the governor or the governor's designee. So it didn't designate a particular state agency. Governor Landry determined that he set the Louisiana Department of Health to be in charge of it. So what will happen is the funding that we get, again, it'll be through a cooperative agreement. So we will get it in under the Department of Health. We will have a separate budget unit for this grant funding. And then, as I'll describe later, we have 20 different strategies. So there will be 20 sub-budget units under each of those that then show specifically where that funding went. We will have to go to the legislature. So we will get the money from CMS. We will set up the budget units. We then, as the money goes out, will be the people through the Department of Health that record how the money is spent, where it went, any money that goes out. But we will also be responsive to the legislature. So we are already scheduled to be on the Joint Legislative Committee of the Budget for January so that we can get the authority to start spending this money. And then we have a lot of legislative interest in this. So while the department will be who manages the money, we will also be responsive to the governor and the legislature who are going to want reporting on this as well. And then again, finally, ultimately CMS. We're not going to wait till the end of the year, of course. We'll have quarterly reports that we're reporting out on.
All right, thank you.
Uh-huh. So again, these are the different categories, a focus on technology, a focus on workforce. There were innovative care, and we'll kind of get into the 5 big buckets that we ended up looking at here in Louisiana. But again, this just gives you the big picture of the different use of the funds that they gave us. They also said that at a minimum, we had to do 3 of these. We did many more than 3, but they did say that you couldn't just pick one activity and put all of your money in that. You had to spend in at least 3 different areas across these 11 different use of fund buckets. They did give us limitations as well around things that you cannot spend the money on, things like any expenses we had before the award or certain types of goods and services, certain types of infrastructure are not allowed, and meals. And so this is the list. And then they also had some unallowable costs. So we did have a lot of folks who said that it'd be great. A lot of the facilities in our rural areas are older and maybe have a need, but they did specifically say that new construction was not allowed. So we won't be able to use any of these funds to help with new construction. There are also prohibits. So we did have a lot of folks who said maybe there's some discrepancies in provider payments, let's say in rural areas versus urban areas. But we weren't able to just take something and say, well, we'll use these funds to do a rate increase and then study how it goes. So if there's something that's already in place and able to be billed, we were not able to use the funds for that. There are some limits around some of the tech pieces in terms of the maximum amount. For our providers, since that's I think our primary target audience here today, they did require that if we do payments for workforce, that we have to make sure that the clinicians are not subject to non-compete clauses in their contracts. And so we added some language there. And then again, some other funding. And so this did sort of shape some of the different information that we included in our application. So that's a summary of sort of what the bill said. And let me know. I don't see Danae coming on, so I think we're good. We'll jump into, well, what did Louisiana include in our application? So as I mentioned, we'll have some points for certain policy actions. And the notice of funding opportunity identified the specific policy actions that they would give points for. So originally we thought, oh, well, we have some other policies in place or legislation in place that we think would be great to help set the stage. But really, these are the ones that CMS narrowed in on in the notice of funding opportunity. So the first being, or one of them being, the SNAP waivers. So we do have now, starting January 1, our USDA approved state waiver prohibiting the purchase of non-nutritious items in SNAP. So no candy, no soft drinks. That's in place, and that gets a state 100 points. We also have the maximum number of points because we do have a legislative requirement in place for our physicians for nutrition in their continuing medical education. There were also points around a certificate of need. And so the way that they look at some of these is across different disciplines. And so we anticipate that we'll get about half of those points. And the certificate of need is that we do have some requirements in place that you have to show that there's a need to expand the provider pool in a certain area. And then there's a group that called the Cicero Institute findings that CMS used. There's also policy action points around licensure compacts. And so when you look at those compacts, that means that folks can practice, across state lines. And with the data metric that they indicated, we would have 100 points in the areas of physician, nurse, and EMS, but no points for psychology and physician's assistants. But we did have in 2024 legislation that passed that indicates that anyone with a license, anyone in the healthcare field with a license is able to practice across states. And so we're going to make sure that we share that information to see if we can potentially get some additional points there. They also look at scope of practice, so people being able to practice at the top of their license. Most of these in Louisiana, or all of these in Louisiana, are really up to the individual boards. And we have seen a lot of debate in the legislature about a lot of these scope of practice bills. But where we stand now in relation to the grant is we anticipate getting about 50 out of 100 points for physician assistant and nurse practitioner, but 0 out of 100 points for our pharmacist and dental hygienist. And then there is also a policy action around short-term limited duration insurance, which we do anticipate getting full points because we do mirror federal practice on that. And that's through the Department of Insurance here in Louisiana. There were also policy points for remote care services in different areas, and we anticipate getting partial points for this. And then we do include, as you'll see in our strategies, some pilots for moving forward remote care services. And then lastly, in terms of policy action, if your state reinstituted the presidential fitness test, then you would be able to get full points. And the Governor Landry did sign an executive order the week before, not mandating that we reinstitute the presidential fitness, but mandating that the Department of Health and the Department of Education work together to get it fully implemented. We have about 30 school districts now who use the presidential fitness, but this will be able to, we'll be able to continue to work to try to promote that. And then when we get into our initiatives and strategies, so we have landed on 6 major initiatives around workforce. We want to strengthen the health and emergency systems through workforce expansion and integration. Around tech innovation, we want to modernize our technology infrastructure and capacity for efficiency and care coordination. And I'm going to get into each of these smaller bullets on the next slides and talk a little bit more and share with you a little bit more around our strategies. But around innovative care, we wanted to reinforce innovative outcomes-based care delivery in rural areas. Under Make Rural America Healthy Again, we want to expand physical activity and nutrition interventions through community-based partnerships. And we also, under Make Rural America Healthy Again, want to strengthen our care integration for high needs populations through coordinated multimodal models. And then finally, through the sustainable access, we want to strengthen access to essential health services through capital investments. So getting into each of those strategies a little bit more, in terms of the workforce strategies, you guys may be familiar with a fund that we currently have in place called the HERO Fund, which is the Healthcare Employment Reinvestment Opportunity. It's a grant application that partners currently put in an application for, and they're reviewed once a year. And then investments are made. And typically it's healthcare training and education programs partnering together with the Rural Hero Fund or Rural Health Hero Fund. This will be similar to what they have in place now with Hero, but it will be targeted to rural health facilities. So it'll be opportunities for people to pull thinking together, apply for funding to look at how we invest in our workforce in rural areas. We will also have a strategy around a rural clinician credit bank. And what this is this gives an opportunity for rural facilities, and I will make sure that I make clear throughout all of the grant, you'll see that we talk about rural facilities. And when we say rural facilities, that for us, that's our rural hospitals, our rural health clinics, our FQHCs, our school-based health clinics, any of our behavioral health facilities that are in rural areas also qualify as rural facilities. And so we did not each time kind of go in and make that whole list. Our assumption is that it is any of those facilities or independent entities across the state that are in rural areas who would be able to qualify for these particular strategies. But with the Rural Clinician Credit Bank, this is an opportunity we heard. So CMS did come back and say we had thought about expanding our loan forgiveness programs or help with that. And they came back and clearly said, no, you can't do that here. But what this will do, it will allow a rural facility to make an application to us for either recruitment or retention bonuses. And so it would be up to the facility to share with us sort of what is your plan. If the plan is, and it can be both, but if you're trying to recruit new people, you can get them in and be able to use this funding to then reinvest in that. But we also heard clearly from folks that we need to be careful that we're not only focusing on recruitment, because you have some clinicians who've been there and stayed there a while. So we also need opportunities to think about retention. So the facility could also ask for a retention bonus. So some of this, we're still working through the details, but the idea would be that the facility would send us a plan. We would approve the plan. Once those payments were made, you would invoice us, and then we would be able to reimburse for those recruitment and retention bonuses. Okay. Yes, ma'am. Danae, I see you have a question.
Yeah, so we have a couple related to the Hero, and then I think one related to the bank. So for the folks trained through the Rural Health Hero Fund, will there be a requirement that they stay and work in rural areas?
Yes. So the grant was very specific that anytime you have anything we're doing in workforce related to any of these that are not, there's only one. So in high school, it doesn't matter, but anything you're doing beyond high school, there has to be a 5-year commitment to work in a rural area. So we will have to have contracts or something that those folks sign. So whether that's Hero or this clinician bank I'm talking about, you will, before anyone gets any funding, they will have to have a contract that they indicate that there's a 5-year commitment to work in a rural area.
Okay. And then the next one, it kind of builds on that. So how will the Hero Fund help rural hospitals with workforce? So I think in that answer, I think, are there specific specialties or anything like that you're looking at for the Hero Fund?
Yeah, so right now it's really open. It can be open to whatever the needs are in that particular area. And we've seen the Hero Fund has been in place for 2 years now, but it has primarily been with larger facilities, more auctioners and Lady of the Lake and things. And so what we really want to do is be able to focus on where are those needs and what might that look like. So the thing that's nice about the Rural Health Hero Fund is it's not a specific, we're not specifically saying this is what it needs to be. It's not limited to any, it's not limited to a specialty or primary care. It's open. I think what we'll see with the Rural Health Hero Fund is it'll be able to be more open to what those individual hospitals need. And then it's a partnership with the training institutions and those rural facilities than to build it out. So it's not, I think it's intentionally, there's not a lot of guardrails on it. And so it's intentionally more wide open to be able to make those investments where they need to be. And we also know that it looks different across the state in terms of what it needs to look like. There's not a one size fits all. So it's really going to be open to fitting that community.
Okay, shifting to the credit bank, can the money can the recruitment bank money be used to train residents in rural areas?
Um, Potentially, we do have another initiative around residents and building out residencies in those areas. I would say the clinician credit bank is more after you would hire them. So there would be that bonus, kind of like that sign-on bonus, along with the commitment. But we do have, you'll see in the next slide, some university partnerships and rotations and opportunities we're looking at to build out those rotations in rural areas as well.
Okay. And then I think you haven't quite gotten to this one yet. So I'll read the question, and then if you feel like you'll answer it later, we can get there. So the strategies highlight risk-sharing arrangements and innovative care models that are not traditionally billable. How will the
Yeah,
state? Yeah.
that's
How,
coming.
yeah. Do you want to wait on that question until we get to that?
Well, you can read it and I'll try to answer it. How will the state what? Sorry.
How will the state support facilities that have the will to adopt these models but lack the operational bandwidth to stand them up? Is there a mechanism for partners to provide the operational lift so facilities can begin producing measurable outcomes faster?
Yep, I'll definitely hit on that when we get to that slide.
Okay. And then I did not see maternal child health specifically called out in the priorities, but from the task force, this has been discussed. Is maternal child health a priority?
Yes, it's the way that the grant is laid out. We didn't really get into specific populations, but yes, that is a priority in the overall term of how they can fit into different areas. And we talk a lot about care navigation. We hear a lot about that in that space. And so rather than being population specific, I think we were broader. But as we get into some of the innovative care models and some of the Make Rural America Healthy Again, there are opportunities then to get specific into the populations. In addition to that, so I would say we've heard a lot about cancer navigation, maternal health, and substance use probably are the larger ones that are coming to my mind right now. But again, we didn't in the application get specifically focused on populations, but rather kept it more open. And so that, for example, the care navigation, depending on which model we need to look at, we could flex to those different areas.
Okay. Okay, I think that's all for this slide if we want to keep going.
Okay. Also in the proposed workforce, there's tax incentives. So Representative Miller, I think it was 2019, had a small town rural tax credit. And that was for people either moving into rural areas or either relocating or in rural areas to be able to get a tax incentive for a period of time. And so we did see in the Office of Public Health, that's where they would go through. There were, I think, over 400 people who applied in 1 year. And if you think about it, 400, physicians or medical practitioners, I think it was nurse practitioners, as well as medical physicians were able to qualify. And so we do have buy-in from the legislature to re-implement that tax incentive for those in rural areas. We will be looking to do that in legislation, either this upcoming session or the following. The only reason we wouldn't be able to do it this session is because it's not a fiscal session. So we're trying to figure out if we can get that in place soon. And then, this one, the new education or training pathways, this really gets more into where we were envisioning sort of students. So this would be having universities or other uh, entities having the rural facility and the university or teaching institute pair with each other. So to build more of a clinical rotation. So for example, we know that there are more students who would like to go into nursing, but there's not enough bandwidth in most of our nursing schools to support all of the people who apply and qualify for that program. So the idea here is we would use grant funding to have opportunities for the university or teaching institute to partner with the rural facility. They would have students who would have to agree to go into this rural training, and we would add teachers on the university side, but then we would also help the rural facilities, because one of the things we heard is that there are a lot of rules and requirements that make it difficult sometimes for our rural facilities to support those rotations and residencies. So the funding would apply both on the facility side as well as the teaching side to give the funding to, again, increase the number of students who are enrolled, but also with a focus on rural health and with getting those rotations in the rural areas. And then we also heard a lot about the fact that we need to not just focus on, doctors and nurses, but that we need to really think about community health workers, EMTs, other allied professionals, billing and coding folks. And so this is starting to look at, in combination of that, we also heard don't try to recruit people from urban areas to go to rural areas, but we really need to start in schools in rural areas with mentorship programs or education. And so these are, you might have heard grow your own or things like that. So this is looking at opportunities to work on building that pipeline. We also have heard that there were a lot of need for specialists or other providers, but that there may not be enough to support a full-time specialist in a particular area. And so the next strategy around the collaborative provider networks is to have funding to facilitate and enable our rural healthcare facilities to be able to share specialists or clinical staff through structured rotation or coverage agreements. And so the billing would still be in place for those agencies, but this is trying to help think about how do we stretch or get more more specialists in areas, but looking at it through a collaboration across providers. And then lastly, in the terms of the workforce, looking at strengthening our emergency medical services by expanding capacity. We know that there's been some studies that have great promise around community paramedicine and integrating EMS into care coordination. And so we'll be doing some pilots to help us study that a little bit better. All right, in terms of moving on to our tech innovation strategies, we are looking at purchasing a single statewide electronic health record that would be managed by us, the state of Louisiana. It would allow any rural facility or rural provider who wanted to be a part of it would be able to through this funding, use the statewide instance of this electronic health record. We would use the funding to also train the providers or the facilities around how to use it. We provide the training around interoperability and what was needed. What would be required in order to make it sustainable is that at the conclusion of the grant period, we would need to have some assurance that that facility or provider would then be responsible for the maintenance cost, ongoing maintenance cost. But all your initial startup, get going, those pieces and training and support would be provided to the rural facility through this grant opportunity. We do feel like this is going to allow us to really be able to do things differently in terms of the provider experience and potential for reducing in excess labs or other activities, but also allow you to have better access to knowing when patients are seen in multiple different areas. There is also something called a Rural Tech Catalyst Fund that allows you to make some investments to then use for rural health areas. That one is one we're going to have to build out. It was not super clear in the notice of funding opportunity. And as CMS went to give additional guidance, they still seem to have some questions. But we will put some funding in here, and then the initiatives that'll come from it will still have to be tied to these strategies that we're employing. Another strategy is around access to digital literacy, and this is looking at expanding our technology access for rural residents. There's already an opportunity to have smartphones, but this is a platform that would allow us as LDH to push out digital literacy for certain populations. There is the ability, for example, to give educational information to people with diabetes. So it's specific to diabetes. There would be the ability to push out literacy information for pregnant moms, and be able to do that. The requirement for the phone is that they participate in these informational activities a minimum of 5 minutes per week. And again, that information can be pushed out based on what the department sees is critical for that particular population. It looks like we have a question before I move on to remote monitoring.
Yeah, just a clarifying question on the state managed EMR system. Is that available to all rural hospitals?
Yes. And we do know that people have, and we were able to get sort of a list for all the rural hospitals. I don't have it for the rural healthcare clinics or FQHCs, but I did get, kind of what system everybody is using now. And we do understand that if you already have an electronic health record, that there's like certain contract periods that you would have to go through. And so we're considering that as well. So this would be able to come on at the time that your current system is no longer under contract.
And then is this a hub and spoke model? Is the question.
I think so, but I'm not sure. Nicole, do you know the answer to that?
I do not know that answer right now, but we can definitely look into that.
Yeah.
I think that's all so far.
Okay. In terms of the remote monitoring and connected care, I heard a lot from a lot of different vendors who told us about all these new and unique types of remote monitoring that's out there, for which we don't do much of here in Louisiana. Everything from, weight monitoring to, I had never even heard of this. Somebody told me there's now something called a leech that you can put on your arm, and it actually draws blood to do blood tests at some sort. So just all kinds of things that are out there that, on first blush seem as if they might be promising. But again, we felt like we really needed time to study this. And so we have opportunities for grant funding for certain pilots so that we then can implement, if facilities are interested. We wouldn't necessarily go with a vendor where we just said, oh, vendor, we're going to buy this and see if it works statewide. But it's more if your facility feels like there is a need for something like this around remote monitoring and you wanted to apply, we would give you the funding to work with the vendor through that. But again, understanding everybody's needs are different. It would need to kind of be what would fit with your community. And then here's the risk sharing. So we did hear from a lot of folks that the risk sharing is more difficult for our rural facilities as opposed to our urban facilities. You guys don't have, the extra capital to engage in risk in a similar manner because you don't have the money to lose at this point if those risk agreements don't work out. So the idea is, yes, that the state would support the rural facility to be able to engage in these risk sharing arrangements. I will say as well, this is also one of those that we want to build out. So we haven't decided yet. We could do one of two things. One, we could say we could develop a model that, let's say it is, we have like a rural ACO, and we're going to pay a PMPM for that. And the state is responsible for paying that per member per month for that rural accountable care organization. And we assume all the risks and we study it for a year. And then if it works, then the provider takes on a part of the risk, but the state keeps doing it. And then we slowly kind of phase that out over time. So we could develop a single model that then people could apply for, or we could say, no, there's multiple different ways that we could look at this. Let's look and engage in multiple different manners. So that part of it has not been built out yet. That's one of the pieces that we know we need to do more build out on. But the idea is that the grant money, i.e. the Department of Health, is the group that's taking on the risk, not the rural facility, and that we're providing the rural facility with the technical assistance that's needed. So we're not just paying to take on the risk. We're also engaging with the provider to help build the capacity so that it then becomes sustainable down the road because we've built a system or helped facilitate a system that works long term. Go ahead, Danae. I know this one's probably the most confusing.
Yeah. So if an organization's already in an ACO at risk, will the state help with the cost of that?
Potentially. I mean, it's hard for me to just give a definitive yes, no, but I mean, it would possibly be something that we'd be able to look at, and I just need to get more information about that specific scenario.
Okay. So in the scenario, the state and the providers are taking on additional risk, would the payers get less funding?
That's not typically the way that it works. Typically, I don't think, and again, is that meaning, so if the providers are getting more, is the managed care organizations getting less? Is that can you read that question again?
Yeah, it says if the state and the providers are taking on more risk, it stands to reason that payers should get less funding. Has this been discussed? I'm guessing that means MCOs, but it's not 100% clear.
And that's not typically the way that the arrangements work. So, yeah, again, all of that has to be studied.
Let's see. I'm seeing if there's any more related to the value-based care before I jump into different. So would the state be interested in primary or urgent care kiosks or pods?
So that one is coming in terms of scaling telehealth. We have some things around scaling telehealth. What we have said though is, again, we are not interested in like a vendor for telehealth that we would make statewide and say, okay, here's a vendor that we found that we're going to pay money to. If you want them facility, come and get them. It would be more the reverse of that. If your facility feels that it would be great to have some expansion and would be able to support that, if you had startup cost or funding to get that going, then it would be the facility who would apply for the grant, and we would then give the funding to get that started up and going. Because yeah, because we need to make sure that it fits with your system. For example, I had a vendor tell me, and somebody was like, "Oh, that sounds cool. Like they can take this. It sounds just like it almost sounded like it's like a box, and somebody goes in and they shut the door and they lock it so nobody can come in, and then they do their telehealth visit with whomever, and then when they leave, it like sanitizes it. And all I could think is like, I know my mom and daddy are not getting in a box and shutting it and just assuming that's okay. So like, I think it needs to fit with your community, and we don't want to make an assumption that there's one something out there that works for folks' communities, and the facility is the one who ultimately ends up billing for those things. So we need to make sure that any of that's working. So we didn't want to do anything separate from the rural facilities themselves, but like, how do we help embed it? Now we are working on sort of a resource document, because maybe your rural facility thinks, well, we would really like to expand on telehealth, but we're just not sure where what resources are out there to help us. So we're trying to develop sort of like a resource guide that also gives information on where these things might be that folks could go apply for.
Okay. Is there discussion around collaborating with the CMS Transforming Maternal Health Initiative that was recently funded?
There may be. We haven't talked specifically about that.
Okay, and then last one I have here, is there a process for funding through this, challenges related to social drivers of health, specifically related to cancer screening and treatment?
Yes. And I know we're actually running short on time, so if it's
We are
okay, I
going
might run through and making sure we can get through all of them. And then Danae, happy if we do run out of time. If people want to send you questions and you want to send them to me afterwards, if we run out of time, I'm happy to I'm happy to get responses to them and send them back to you to
no
get
problem.
out to folks. The innovative care model strategies are really around, those are the things that are not traditionally covered or billable services, but we know that we've heard a lot about. And this is where, folks were asking earlier around navigation and mobile care and postpartum support. And so we will have grant opportunities to fund those. Under our Make Rural America Healthy Again, we do have investments around establishing food pharmacy programs. We've seen a lot of success with some partnerships around food as medicine programs. We are very fortunate that we have our LSU Ag Centers across. And so what we envision here are some partnerships with the LSU Ag and potentially those rural facilities to build out food as medicine. Also looking at our community-based nutrition and fitness through partnerships. So grants that help look at, nutrition and fitness solutions. Had a lot of work done with Pennington that that's been promising that we can expand on. And then we also, under our Make Rural America Healthy Again, have opportunities around helping to build more substance use facilities in rural areas. We know that those are severely lacking, and folks are having to go far to be able to access that service. We also have strategies around our regional care conveners and navigation networks. Here's the telehealth infrastructure that you guys were asking about. So there will be opportunities to fund activities that help to bridge those gaps. And then finally, alternative PACE sites. So we're limited in terms of the number of PACE sites. This would be, as I said, you can't do new construction, but there are opportunities to use existing structures to expand our PACE locations in rural areas. And then the sustainable access strategies are really around capital improvement. So we heard from a lot of our rural facilities, mostly probably our hospitals and rural health clinics, that they would like to be able to provide other services, but that there's, funding associated with getting new testing equipment or things like that. So this would be an opportunity for facilities to request funding for us through those capital improvement activities. Again, we do have some limitations in terms of construction and things like that, but we do have the ability to spend a certain percentage on these capital improvements. And so, I will share, because some of this you guys have asked some detailed questions. There will be a webinar that will sponsor December 4th at 10 o'clock, where we will take each of these strategies and drill down a little bit more on them in terms of when we anticipate funding be available, what's the criteria, those kinds of things, where we know it. There's some that we won't know by December 4th, like the innovative care model, but we will be, letting folks know how you can apply during that webinar. We also heard clearly from folks that a lot of our rural facilities aren't used to writing grants or need help kind of understanding what it is. So what we don't plan to do is just have a webinar and say, here it is, if you want it, come get it. But we do intend to engage with you guys and really think through how do we make sure folks are aware of these opportunities and know how to apply, and that we're connecting and making partners. We will have a formal rural health transformation advisory group that we established through legislation. And then we'll be looking at regional advisory groups where we try to help facilitate regional partnerships kind of across the state. And we will be doing, Nicole and I, as well as the other folks that will be doing some statewide tours, so that we come out. We'll probably be knocking on your door asking if it's okay for us to come visit your facility or your communities. And I do want to say, so, and I think Nicole wanted to share a few things, so I'll cover these quickly. And then Nicole, if you want to jump in, we do already have a state office of rural health that's currently under our Office of Public Health. And the idea is that we develop we pull those staff in under the same umbrella with this rural health transformation program, so that we have sort of all of the major activities that happen around rural facilities under one section, and that'll report directly to the secretary. And then again, we'll be making sure we get the funding out, and we want to be the facilitator for the engagement. Again, not just with this transformation grant, but for all the other great work that's already happening under our state office of rural health. Again, just combining it. So Nicole, do you want to jump in and say a couple of words before we sign off?
Sure, I sure can. Again, most of you know me and the team in the State Office of Rural Health or Healthcare Access. Eric, Amanda, Kelly, Beth, myself, we are still going to be working hard to support you. We've had the privilege of partnering with many of you for several years, and we remain dedicated to providing the support that you need. Now, again, while programmatic transitions are underway, our commitment to you and your facilities will not change. We are still here, and we're still working for you.
Thanks, Nicole. All righty. Just real quick, Danae, before I turn it back to you, we do have a dedicated website. So happy if you want to send questions directly to us at ruralhealthtransformation@la.gov. If you want to reach out directly to CMS, they have a Maha Rural at cms.hhs.gov. Otherwise, also happy for you guys to send any questions you have that we weren't able to get to today to Danae or to this email address, and we'll make sure to get a response back to you. All right.
Yeah, and
Thank
there's
you.
just a couple of quick things I'll just pull out of the Q&A. They asked if we could if you guys could share the actual application. I don't know if that's something you can share to look
It was
through.
just posted on the website this morning, so you can find it on our website.
And I did post that into the chat. And then there's just a note that MCOs deny payments for opioid inpatient programs, and so payment would need to be required or made there for some of that
Okay.
programming. So just a note on that. All right, and then I'm going to put my email in the chat. to send any questions. Yes. So can you put that last slide up, Julie?
Oh, sure.
Just with the the contact information. Yeah, so that's that there, and I'll put it I think it's in the chat as well. But you can email any additional questions to me, daber@lrha.org, and I'll get those over to you, Julie, or you can send them directly to the Rural Health Transformation. So thanks so much, Julie. We are just a couple minutes over time, so we appreciate your time. We appreciate you being here. Thanks everyone for joining. As a reminder, please do take the post survey. I'm going to pop that link in the chat as well, to make sure that we continue to improve our future programming and identify additional resources that may be beneficial to you. The recording will be up on our website within the next couple of days, along with a copy of the slides. As always, please feel free to reach out to us at LRHA if we can be of any assistance, if you need anything from us. Again, thanks everyone. Happy National Rural Health Day and have a wonderful afternoon.